Hello, I'm Dr. David Cotter, a board certified dermatologist practicing in Las Vegas, Nevada. And today I'm excited to share with you the results of an expert consensus panel on utilizing 31 gene expression profiling to help our patients with cutaneous melanoma achieve the highest level of care. The purpose of this expert consensus panel was to offer the practicing dermatologist, the dermatology NP, and the dermatology PA a best practice model for the appropriate melanoma patient. And what this study did is it looked at a systematic review of all articles published on 31 gene expression profiling. An initial literature search resulted in 150 articles, 26 that met criteria for inclusion to be analyzed by a panel of 10 dermatologists with significant expertise in the management of melanoma. A modified Delphi process was utilized to create 9 consensus statements, 8 of which received a recommendation with a strength of A and 1 that received a recommendation of C. The reason why we're here, why we're doing this, is because we need to elevate the care for our patients with melanoma. Every single year in the United States, there's 100,000 cases of invasive cutaneous melanoma that result in approximately 8,000 deaths. Unfortunately, we don't do a great job identifying which patients are at risk of dying from melanoma. 25% of people that ultimately die from this disease are diagnosed as stage 1. It's absolutely unacceptable. These are patients that we would assume, based on population-based estimates, are going to be okay. Furthermore, 35% of patients that ultimately die from metastatic melanoma are stage 2. Cumulatively, that results in 6 out of 10 melanoma deaths occurring in patients that are initially diagnosed as stage 1 and stage 2. And herein lies the problem, and therefore the reason why we need consensus statements to help guide the management of our patients with cutaneous melanoma. In this article, there were 9 consensus statements, and I'll just go through them because it's worth reading them one by one because these are strong recommendations to help augment the care for our patients with melanoma. The first one is that multiple studies, including prospective studies, have demonstrated clinical efficacy for the 31 gene expression profile test in providing consistent and accurate prognostic information for invasive melanoma. This statement is true. It's been validated over and over again in dozens of clinical trials, including multiple prospective studies. So when you have a patient with cutaneous melanoma, it's great to order the 31 GEP test to help risk stratify them for the badness. Additionally, the next consensus statement is that studies have shown clinical utility for the 31 GEP test for providing prognostic information for invasive melanoma. This one dovetails very nicely off the first statement. And again, multiple papers have demonstrated this over and over again. Studies have shown clinical efficacy for the 31 GEP test in providing prognostic information for invasive melanoma when the thickness or other traditional factors are unknown. This is a very important consensus statement. It's important to get this information out because one of the utilities of this test is when you have a melanoma that's been transected. For example, if you do a shave biopsy of a funny brown spot and it comes back at 0.6 millimeters transected, meaning invasive melanoma extends to the base of the biopsy, we don't know the true Breslow depth of that lesion. And that can lead to confusion and ambiguity over how we manage that patient. Should they go on for additional testing, such as a sentinel node biopsy? Do they need to be referred out of our general dermatology clinics? Well, there was a fantastic paper that was done with the lead author of Dr. Whitman that looked specifically at identifying how the 31 GEP test risk stratifies patients even in transected melanomas. And in that study, up to 40% of the melanomas were transected, but irrespective of that, the GEP accurately predicted who was going to go on to have a positive node or not. So we can rely on the gene expression profiling test in scenarios where standard staging methods fail us, which is why the next consensus statement makes sense. Integration of the 31 GEP test with traditional staging methods can accurately inform the decision to recommend sentinel lymph node biopsy. And now there's multiple studies that not only demonstrate that we can predict who needs to get it done, but also demonstrate who can avoid it. There's a series of papers that have shown anywhere from a 20 to 30% reduction in the number of unnecessary sentinel node biopsies in patients that have a low risk gene expression profile score. What we're talking about here are folks with things like a T1A high risk or a T1B or even maybe a thin T2A tumor. So anywhere from 0.6 to 1.2 millimeter Breslow depth in my practice, I find a lot of utility in using the GEP test to avoid an unnecessary sentinel node biopsy. Because when the GEP comes back as low risk, meaning less than 5%, those patients in those types of Breslow depth ranges can safely avoid an unnecessary sentinel node biopsy. And that again relates to the next consensus statement. There's a statistically significant improvement in assessing prognosis when adding 31 GEP results to AJCC8 staging. What we're talking about here is not GEP versus AJC, but rather integrating GEP with AJC. Because in a recent paper that was published in the Surgeonc journals, it looked specifically at gating patients based on their T staging and their AJC stage, and then applying gene expression profiling to help refine the patients that go on to have a sentinel node biopsy. And it did a very good job. We're talking about a negative predictive value of 100%, meaning that we can avoid nodes in people that don't need them without missing anyone that would. Furthermore, when you use the GEP to risk stratify stage 1 melanoma patients, it does a better job than AJCC8 staging when it comes to melanoma-specific survival. Stage 1A and stage 1B patients in AJCC8 don't seem to have a difference in melanoma-specific survival, which is concerning because these are patients that are different stages clinically. But when we risk stratify them based on the 31 GEP test, we can actually break them apart even from an intra-stage standpoint, with class 2B patients on the 31 GEP test consistently doing worse. But don't we have other tools that we can use? Why do we need GEP? Can't something like an online nomogram do just as well? Well, actually, no. Online nomograms are helpful, but there's now a series of papers that demonstrate 31 GEP testing is more accurate and precise than online nomograms in predicting the need for sentinel node biopsy. Furthermore, patients who have had 31 GEP testing have improved melanoma-specific survival and overall survival in comparison to patients who have not received 31 GEP testing. That's the most poignant of the consensus recommendations, and getting that information out throughout the House of Dermatology is very important. What people need to recognize is that when someone with a melanoma gets a 31 GEP test, they're more likely to survive that melanoma than a matched patient who doesn't. Probably because we are identifying risk and then getting those patients a higher level of care. Maybe they get a sentinel node biopsy that they wouldn't have. Maybe they get an imaging test that they wouldn't have. And likely they're being followed more closely so that if they do have a recurrence or metastasis, we detect it right away. Now, this next consensus statement is the only one that didn't receive a recommendation of A. Everything else we've talked to this point has an A recommendation. This one has a C recommendation. And that consensus statement is limited data suggests that patients are more likely than not to be receptive to receiving the data from the 31 GEP test in the discussion about their invasive melanoma and management. So a C here is not because it's not a good idea to use the test. It's because when we grade the evidence, it's based on the combination of types of papers that are out there. Prospective clinical trials receive the highest level of strength in our evidence analysis, followed by systematic reviews, network meta-analyses, and then as we get farther away from those more robust clinical studies, we have a lower quality of evidence. And the types of papers that support the role of how patients will be receptive for GEP testing just haven't been done in a prospective manner the way that some of these other consensus statements have. But I still think it's a good idea. And in my practice, patients do like having more information. I've never had someone say, no, I don't want to know what's going on with my melanoma. And that brings us to the last consensus statement. The existing data strongly support the utilization of 31 GEP testing as a best practice for the appropriate melanoma patient. And I like that term best practice because that's what we're aiming for. We're aiming to augment the level of care we offer our patients. And we can utilize 31 GEP testing to do exactly that. Thanks for listening.